Last class, the liver failed, both as a passage for blood and as a set of jobs. Today we finish this block one duct downstream with the gallbladder and the pancreas. The whole session comes down to one sentence. Where the stone is decides what the disease is. Get the plumbing in your mind first, because everything after it is geography. Bile is made in the liver. It leaves the liver, it's stored and concentrated in the gallbladder, and it drains out through the common bile duct. The pancreatic duct joins that same drain just before it empties into the duodenum, which is the first part of the small intestine. 3 organs, 1 shared pipe.
Stones first. Bile is a solution, and solutions crystallize when their ingredients get out of balance. 3 things tip it: too much cholesterol in the bile, too much bilirubin pigment, or a gallbladder that empties poorly and lets bile thicken and concentrate. Crystals grow into stones, and that condition is cholelithiasis. Here's what surprises people. Most stones cause nothing at all and get found by accident. A stone is harmless until it moves. Trouble starts when it does. The patient eats something rich, and the gallbladder is told to squeeze. If a stone is stuck in the outlet, the gallbladder squeezes against a closed door, and the pressure inside it climbs. That pressure is the pain. It's cramping pain in the right upper belly after a fatty meal, sometimes reaching up to the right shoulder, and then it fades. Pay attention to the reasoning, because your quiz tests it. Fat doesn't change the color of bile. It doesn't inflame the liver directly, and it certainly doesn't dissolve stones. Fat pulls the trigger by ordering the squeeze, and squeezing against a blockage is what hurts. Now let the stone stay stuck in the gallbladder's own outlet, the cystic duct. Trapped bile concentrates and irritates the wall. The wall swells and inflammation sets in. That's cholecystitis, and the story changes. The pain doesn't come and go with meals anymore. It's constant right upper pain with fever, nausea, and a tender belly. Hold on to that difference. Colic is a squeeze against a blockage that passes. Cholecystitis is the blocked organ getting inflamed. It isn't painless, it doesn't settle within an hour, and it doesn't require the absence of stones. On examination, the patient catches their breath when you press the right upper abdomen while they breathe in. That's an inflamed gallbladder objecting to being touched. Ultrasound, in concept, shows you the stones, a thickened wall, and fluid around an angry gallbladder. Repeated attacks scar the gallbladder, and a blocked, infected one can die and perforate, which is why the definitive treatment is usually to take it out. Move the stone further along now, into the common bile duct itself. Bile dams up behind it, so the patient turns yellow. The stools go pale because bile isn't reaching the gut, and the urine darkens. Then the trapped, stagnant bile gets infected. An infection in a blocked duct has nowhere to drain. That's cholangitis. Burn the triad in: fever with shaking chills, right upper pain, and jaundice all together. That combination means infected bile under pressure with a straight route into the bloodstream, and these patients slide into septic shock. This isn't the moment for diet teaching. It isn't the moment to try an antacid, and it isn't the moment to schedule an outpatient scan. The duct has to be drained because medicine alone can't reach infected bile trapped behind a closed door.
One more location, and it's the worst one. The pancreas makes powerful digestive enzymes, and it ships them inactive. They're switched on only after they reach the intestine. That's a safety design. Block the shared drain at the duodenal end, and the enzymes activate early while they're still inside the pancreas. The organ starts digesting itself. That's acute pancreatitis, and two causes dominate: a gallstone at the shared drain and heavy alcohol use. It isn't an infection of the gland. It isn't an autoimmune attack on the insulin-producing cells, and it isn't blocked insulin release. The pancreas is being digested by its own enzymes. You can hear it in the story. Sudden, severe, boring pain high in the abdomen, drilling straight through to the back, worse lying flat and a little better curled forward with vomiting that won't stop. The injured gland leaks its own enzymes into the blood, so raised lipase and amylase are the laboratory signature. In severe disease, you may see bruising creeping across the flanks or around the navel, which is blood tracking out from the inflamed tissue behind the abdomen. Now, here's why this becomes a whole body illness. Because the danger in the first day isn't the pain. Activated enzymes don't stay put. They leak into the surrounding tissue and into the bloodstream, and the inflammation they set off goes body-wide. Fluid pours out into the inflamed abdomen, and the circulation can empty into it. The patient is dry, the heart is racing, and the pressure is drifting down. That's hypovolemia and shock, and it can empty the vessels the way a hemorrhage would, without any blood you can see. Watch the circulation first. Digested fat also binds calcium in the abdomen, so blood calcium can fall. Enzyme-injured lungs get stiff, which makes severe pancreatitis one of the classic triggers of acute respiratory failure, and we'll pick that thread up later in the course. And a pocket of enzyme-rich fluid can wall itself off as a pseudocyst and stick around long after the attack is over. Chronic pancreatitis is a different problem. Acute disease is one episode of self-digestion. It ranges from mild swelling to widespread tissue death, and it can recover completely. Chronic disease is repeated injury, most often from long alcohol use, until working tissue gets replaced by scar. That scarred gland fails at both of its jobs. Too few enzymes, so fat isn't absorbed and the stools turn greasy. And eventually too little insulin, same organ, same enzymes, but one is a single attack and the other is years of damage adding up. So here's what to bring with you. A fatty meal tells the gallbladder to squeeze, and squeezing against a stone-blocked outlet is the pain of biliary colic. Cholecystitis is that blockage staying put until the organ inflames, so you get constant pain, fever, and tenderness that catches the patient's breath. Fever with shaking chills, plus right upper pain, plus jaundice is cholangitis, and it's an emergency that needs the duct drained. Acute pancreatitis is enzymes activating inside the gland and digesting it, from a gallstone or from alcohol. And in the first day of severe pancreatitis, what harms the patient fastest is fluid pouring into the abdomen and emptying the circulation. In class, we'll work through Ms. Okafor. She's had a year of right upper pain that comes with meals, and now it's turned into something drilling through to her back. Then we'll close the session with the structured Exam 1 review for this block. Finish the Module 45 gallbladder lessons before you arrive. See you in class.